Good afternoon. Good afternoon. Thank you. Thank you. It's so wonderful to see you all here this afternoon. I want to welcome you to kind of the kickoff to our wonderful Founders Day weekend. I know there's lots of students here. We're being live streamed to other classrooms. I know there we have alums, we have staff, we have honored guests from many of our national associations. So I want to welcome all of them to this opportunity to celebrate our history and our founding and our present. And, looking out at the sea of students here, it's just inspiring to think of our profession and its growth and its future, which is good. It is just truly my honor today to introduce our speaker of the Fred C. Tenning Founders Day Osteopathy Lecture. A little historical fact, Dr. Tenning was president here for many years. He was a known exceptional leader in the osteopathic profession, promoted our profession, and did a lot for not just our school, but for osteopathic medicine. And in his honor, this lecture was established to each year on Founders Day weekend to kind of promote the profession, bring back an exceptional speaker who could talk and tell us a little bit about their pathway and some exceptional things that they've done. So for me this year, it's especially special to bring back one of our own. This is Dr. Ariana Peters, who was a 2003 KCOM graduate. And it's just a real thrill to have her back here on campus in this role this year. I'll tell you just a little bit about Dr. Peters. She graduated from KCOM in 2003. She did her residency in internal medicine at Beaumont Hospital, which was formerly Botsford, in 2007. She then worked in a number of places out west, Albuquerque, and landed in Arizona at working as a hospitalist. And though she found that very exciting and satisfying, she also recognized it had a lot of challenges. So after 10 years of clinical work, Dr. Peters found herself looking how she could make a greater difference beyond direct patient care. And in 2015, she was approached to become a physician advisor. As a physician advisor, Dr. Peters has become more involved with care management and clinical documentation integrity. She became the care management medical director and lead physician advisor at Mayo Clinic, Arizona in November of 2019, and the lead physician advisor for CDI in early 2020. Since then, her responsibilities have expanded to include acting as a liaison between hospital administration and providers and staff, provide education, and lead projects expanding across the Mayo Clinic enterprise. So again, my great honor and pleasure to welcome back and to introduce to you Dr. Ariana Peters. Dr. Peters.
Thank you, Dr. Wilson, Dr. Kirsch. I want to say a very special welcome to all of you. This is wonderful to see all of you here in person, and all of you that are next door, that are live streaming. I want to say thank you for your attention and for being here to listen to these words and to these. Hopefully, you learn something coming out of this. I also want to personally thank the Tenning family for being such an honor to be chosen to give this lecture. I knew Dr. Tenning very, very briefly, and I know his daughter, Laura. Dr. Reister is her last name, married name. And so, I wanted to, this really, to me, is very special. In a way, it's a really coming home. I can't even believe that it's been 19 years since I've been back here. So many things in Kirksville are exactly the same. The Duke of Min is still the same. Thousand Hill State Park is still the same, but there's an Old Navy and Marshalls, and I was like, wow, this is amazing. This is great. More than Walmart and Hy-Vee. So, and at the time when I was here, that's pretty much all there was. But what's very special about KCOM is it really is a family. It is a small town environment where you really get to know your fellow classmates and your professors. And maybe I'm a little bit biased, but the training, in my opinion, is the best. And so you guys are very lucky to be in the positions that you are in. It's my understanding you're all first-year students, correct? Okay, everybody nodding our heads. Who all knows what they want to do? You can raise your hands. It's okay. Nobody. Oh, a few people know what you want to do. Okay, all right. It's okay not to raise your hand, right? It's okay. You're still in the process of learning where you are at this current stage of your careers. But we want to start to think about these things as you start to learn more about medicine, and as you move through your first year into your second year and onto your clinical rotations, there's more things that you need to know about taking care of patients than simply taking care of patients, right? Of course, patient care is our primary outcome and goal. We want to take good care of our patients. But there are things that can help you along the way. There are other paths, other things, and other ways that you can help to care for these patients. It's more than just care at the bedside, right? And what are our tenets of osteopathic medicine? Mind, body, and spirit, right? So the things we're going to talk about today have to do with those exact three things. How can you parallel those things that you know about in class, that you've learned about in your OMM skills, and that you've learned about here in the classroom, and take that and apply it into your work in clinical medicine? And it doesn't just apply to the hospital, although a lot of this talk certainly does, because a lot of the patients that you care for are going to be in the hospital. But not all of them will be. And so it's important for you to remember that it's more than just the bedside care of the patient, which of course, obviously is immense, but there's other aspects to the care of patients. It's the care of their families. It's the care of their mental health. It's the care of the whole patient. And that is really what the fundamental of care management is really all about. And so if all of you walk away from this having some basic understanding of that, then I will have done my job today and hopefully get you to understand how care management can help you. I'll tell you guys a little short story and then we're going to move on with the lecture. But so when I was a third year student, so brand new, I think it was my second rotation ever, first rotation in the hospital. First rotation was in clinic and family practice. My second rotation was internal medicine as a third year student. And I remember I was presenting a patient to my attending, and he asked me a question about something to do with the patient's psychosocial needs, their placement needs, something like that. And he said, we got to consult care management. And I looked at him and said, what's that? I had no idea what care management was. Who here knows what care management is? Okay, we've got one person raising their hand, not very many. Okay, all right, then I have a good job to do to the next hour. So hopefully you all will walk away from this having a good understanding of how care management can help you take care of your patients. And I think applying some of the principles of care management, not only to your patients, but to yourselves. We've been through an awful lot in the past couple of years. There's been a lot that's happened. A lot has changed in our world. And I'm going to share a little bit of some personal stories about that towards the end of this lecture. So with that, we will move on. So this is obviously things that we have to kind of get through. That's me with my fancy picture. Okay, so some of our objectives today. So we're going to review the official definition of care management within the U.S. healthcare system. We're going to talk about how care management is the link that can provide care between the hospital and the community, back and forth between acute care, meaning in the hospital, and then into the community, and then back and forth. We're going to meet the members of a care management team and how each of those can play a distinct role in the care of the patient. How can they help you apply the tenets of osteopathic medicine that you are learning while you're sitting here in this very classroom and down the hall in your OMM classroom? How can you apply those principles and parallel them to the care of the whole patient? We're going to talk about how care management ensures a safe transition in and out of the hospital, and like I said, directly impacts the care of the entire patient, and how those parallels exist between those principles and between that and osteopathic medicine. Then we're going to talk a little more about a personal story, some personal stories that I'm going to share with you about myself and what led me to this particular path, and how I applied simply the concepts of care management to be able to have self-awareness, self-care, and that professional motivation that you all are going to need. Medicine is not an easy job. It's rewarding, and it's wonderful to do, but sometimes it can be hard. It can be very difficult. You're going to be faced with very challenging situations when you have tough discussions with your patients and their families, and you need to know how to be able to handle that for yourselves on an emotional basis, because you are to be their guidance. You are their rock. You are their person to help navigate them through a very difficult and challenging time in their lives, potentially. So how can you care for yourself in this process as well? So those are the important things we'll talk about. I have to have this up here. I have no disclosures that I have to mention. So we're going to start with a patient. This is a real patient. I realize there's a lot up here, so I'm going to read it to you. So this is a real patient that I saw a few months ago. 76-year-old female. She has a past medical history significant for coronary artery disease. She's had some stenting. She has hypertension. She has hyperlipidemia, COPD. She has acid reflux, GERD. She has oral carcinoma, and that was resected. She presented to the emergency department with a 1-week history of falling and bilateral lower extremity weakness. She had fallen 3 to 4 times at home within the past couple of weeks. She also noted that she was losing losing weight. She had lost about 15 to 20 pounds over the past month, and she had increased her caloric intake, including eating banana splits. She had done that to try to gain some weight. I wish I could do that. That would be way great, but not possible. So she had gotten in contact with her primary care physician, and he thought that potentially she might have had a TIA, or transient ischemic attack. So he kind of said, keep monitoring things. I'm going to keep a close eye on you. And she had started to use a walker at home because she was afraid of falling. And she specifically noted that she would kind of fall to the right during these episodes. And she had developed some headaches over the past week prior to her presentation. And so she called her PCP back, and the PCP said, go to the emergency department. So what are we concerned about? Let's talk about what you're worried about with this patient. Just raise your hands. It's okay. Question. Yes. And I'm going to repeat it for those that are on the live stream.
I'm worried about a hip fracture.
Worried about a potential hip fracture. Okay. What else? Yes. Go ahead.
Worried about stroke.
Stroke, potentially. Okay. What else? Yes. Lives alone, falling, can't get up. Okay. What else? There's more. Yes. Recurrence of cancer or potential cancer. Okay. What else? Cancer, same thing. Okay. What else? She's eating banana splits to gain weight. She's lost some weight, right? That's not a good thing that you're supposed to do that. Okay. All right. So these were things that when I read this chart and I looked at this patient, I thought, ooh, okay, we've got a lot going on here, right? And not only that, but she also had a wedding. And what I didn't put in this story was that her granddaughter, one of her favorite grandchildren, was about to get married within a week after she presented to the emergency department. And it was very important for her to get to that wedding. And so that was a very important piece to her and something that she talked about frequently when we were discussing what our plans were going to be, because she was trying to figure out how can I get there and how can I still manage all of this that's happening to me, because it feels like my entire world has changed literally within a day after I came back or after I presented to the emergency room. Okay. So what did we do? So upon workup, so she came into the emergency department, got a CT of the head. She had a right frontal mass with vasogenic edema that was concerning for a primary brain neoplasm versus metastatic disease. She had a CT of the abdomen and pelvis, and that noted small bilateral adrenal lesions, which were suggestive of adenomas. CT of the chest showed an anterior segment left upper lobe lung mass, which was suggestive of a primary lung malignancy in the setting of emphysema. She had nodal metastatic disease and likely pulmonary mets within her left lower lobe. Also visualized were additional sub-centimeter upper lobe ground glass opacities, likely pre-invasive adenocarcinoma spectrum lesions. Now what are we concerned about? Cancer, right? Okay. What else? What are we worried about? She's got swelling in her brain, right? So we're worried about the edema, okay? That's causing some changes in her brain. And what else are we worried about? It's in her lungs. So it's probably metastasized, right? Okay, so we probably have a cancer diagnosis at this point. Don't really know exactly what it is, but we probably have a diagnosis of cancer. So now, obviously, things have changed in terms of her entire world is now abruptly different than it was even one day prior before she came into the emergency room, right? So now what do we do? So I wanted to highlight just some of the things that when I read this case, this is what concerned me too. So all the things that you guys have talked about, so good job. And I'll tell you what happened. So we tried to figure out what to do with this patient, and the consult originally came from neurosurgery, actually, and they were trying to do a resection of the mass in her brain. And I said, well, it might be a good idea to talk about maybe going after something that might be a little easier to get to, like not the brain, like how about the lung? We can try that instead, or maybe one of those metastatic spots. And so we talked about that. But that's when the patient brought up the fact that she wanted to get to her granddaughter's wedding. So then we had physical therapy see her, and physical therapy recommended rehab for her, but she couldn't go to the wedding if she went to rehab. And she kept talking about the fact that this was very important to her and that no matter what, she had to be at this wedding, and there's no way that you can go to rehab and then go to the wedding and then come back. So we talked about the fact that her cancer was probably metastatic, that it probably wasn't going to be good news, that it was probably lung cancer. And then we talked about hospice, and we talked about potentially what could that look like for her in terms of end-of-life care and making her more comfortable, and how we could help her along the way of that path. She didn't ultimately choose hospice right then and there, but she did want to try to get some brain radiation, which we offered to her because that could be done on a palliative basis as an outpatient. So she could come and go for her radiation, go to her granddaughter's wedding, and then kind of make a decision from there. And so that's what we ultimately ended up doing with this patient. And she was very grateful because we talked about everything concerned with her care. We weren't just zeroing in on, we've got to clear her for this procedure, for this biopsy. We talked about the importance of things to her that were important in terms of her mental health, in terms of her family, in terms of all the things that place such high importance for her. Those are the things that we spent time talking about. And so that's where care management, one of the things that care management does. And we're going to talk about some of those transitions of care. And that's why this case was such a great example, because it literally had everything in it. So, what is the definition of care management? So for those of you that raised your hands, there was like 2 of you that knew what care management was. Here's the definition for you, right? So this is what it is. So care management and healthcare delivery systems is a collaborative practice, including patients, caregivers, nurses, social workers, physicians, payers, meaning like the insurance companies, support staff, other practitioners, and the community. And the care management process, or case management, you'll see it kind of used interchangeably. Process facilitates communication and care coordination along a continuum through effective transitional care management, recognizing the patient's right to self-determination, the significance of the social determinants of health, and the complexities of care. The goals of case management include the achievement of optimal health, access to services, and the appropriate utilization of resources. That sounds an awful lot like the tenets of osteopathic medicine, doesn't it? There's a lot of parallels there, right? And so to me, it just struck me as something that is just inherently similar to what you guys are already learning as future osteopathic physicians and part of the practice of medicine in general. So what are the scope of services of care management? I am not going to spend time explaining every single one of these things to you, but I will explain a few things because you may not know what some of these things are. And while you're not necessarily needing to know them right now as first-year students, but I can guarantee that our attendings that are on the live stream, and even some of our students that are a little further along, they do understand that you do need to understand some of this, right? So utilization management, in a very short explanation, is how we deal with payers, with insurance companies, and getting paid for the work that we are doing, making sure that patients are in the appropriate status. You may have heard about things like observation or inpatient status. It's kind of a hot topic across the country, especially for Medicare patients. So again, while you think that all you're trying to do is take care of the patient, you do have to think about some of these other things because this is part of their care. It's not just the medical part. It's not just the I'm ordering the CT for this particular thing. There are other things that you do have to think about in the backs of your minds as you're taking care of these patients. And inherent to that is utilization management and also resource management. Do you really need to get that x-ray of the knee for the patients that's saying that I've had knee pain for 12 years, but they're in the hospital for pneumonia? You probably don't, right? So trying to use your resources appropriately. Remember that patients get bills at the end of their care. A patient gets a bill for everything that you do. And so while, again, you may think that you're trying to take care of the patient, your first goal is to take care of their health, remember that things like that happen on the back end that you may not think about in the forefront of your minds when you're ordering 10,000 tests. Addressing psychosocial, financial, spiritual needs. That's part of what care management does. Social workers are an inherent part of the triad of care management model, which we'll talk about. Tracking and reporting regulatory compliance. We're subject to this, and it's something that we all are part of within the medical system. And so remembering that as you go through your learning experiences, again, it may not necessarily be in the forefront of your minds, but it is something that you do have to consider and think about, especially as you move through your medical training. Denial management. We want to be able to be paid for the services that we're doing. Right? We need to be able to continue to care for patients. And so preventing those denials is part of your work, as part of the medical team, as part of your clinical documentation. Part of the work that you do is to prevent those kinds of denials from happening. And then facilitation of transition of care and the discharge process, to work on readmissions and readmission prevention. And then, of course, spiritual care and the chaplain services. And then any provider relationships and potentially even preferred providers, if you have providers that you've connected with that your hospital works with closely, those kinds of things. Those are also very important. And then charity care also for those patients that are indigent or cannot afford care. This is where care management helps with all of this. And I think you're seeing a theme here, right? The tenets of osteopathic medicine parallel this incredibly closely. All of these things are important in the care, the whole care of the whole patient. And those are the things that we want you guys to understand. So, care management is the link. We call this our lung slide, right? Because it looks like the lungs, right? So Care management is that link, right, between the acute care setting in the hospital and then out in the community and vice versa. So you have your care coordination team, you have your transition case managers on the floors, you have your medical director, in this instance that's me. You might have quality involved, you might have ethics involved. Revenue cycle is actually the cycle that it goes through when a payment goes through from the hospital and you send out the bill and then the insurance company pays and then you close out the chart and the patient pays their copay and it closes out the whole bill. That is what revenue cycle actually is. I didn't even know what revenue cycle was until I started doing all of this. I had no idea what the definition even meant. But the bottom line is that you actually do have to understand a little bit about this. Can you walk away from here saying, I know everything about Medicare? No. Do I expect you to? Absolutely not. I don't even understand half of that stuff. But the point is that you need to have it in the forefront of your minds as you are taking care of these patients. What is important to do while they're in the hospital? What can be done as an outpatient? These kinds of things do play into the part of the care of the entire patient. You have hospital administrators. Of course, you have nurses. You have the medical practice in general. You might have a chief nursing officer. You might have an office of patient experience. We do at Mayo Clinic. But every hospital has some kind of an office where the patients can bring back their concerns or kudos to their medical care team. Right? All of these things play into the care of the patient. And then care management links them to the community. And you can see on the right-hand side, you can see the community providers that are out there. There's skilled nursing, there's palliative care, there's home health agencies. All of these things are players in the care of the patient and hopefully the prevention of readmissions. And so it's important to remember that you need to communicate with these providers on an outpatient basis to remember that they're helping to keep those patients at home in their happy home environments where they need to be, where it's better for them to be, hopefully. So that's an important thing to remember. And care management can help you with all of that. So there's a lot of people on this slide. I am not going to expect, there won't be a quiz, I promise, no test or anything like that. I'm not going to expect you to remember all of these things that are on here. And we have a lot of people at Mayo Clinic. We are very, very blessed. We have a lot of people helping us to do all of this very hard work. Not every hospital that you go to is going to have all of these people. This is kind of the ideal setting, right? But you can see the umbrella of what care management covers. It covers everything from your nurse administrator to your RN case manager. And by the way, maybe you may not even know this, the difference between care management and an RN case manager. Care management is the field that we're talking about. An RN case manager is a nurse. And they're the ones that are working on the floors. Or they might be doing utilization management, or both. So you can see all of these members are part of a really big team. And it is all these people that help to facilitate the care of that whole patient. And so there's certain important things that I wanted to point out on this slide, and that's our little triad, what we call our triad model of care management, which is the social worker, the RN case manager, and utilization management. Now, you mentioned that on one of the prior slides, right? So your social workers, what do social workers do? A lot. Yes, they do. Yes, they do. What do they do? What do social workers do? Resources. Okay, resources in what? Counseling. Okay. And what else? Okay. What else? Yeah, go ahead. Okay, all right. So what was said was helping to set up rehab, maybe looking at the home environment, things like that. Sometimes social work does that. Sometimes that's actually the RN case manager that does that. So it depends. So in hospitals where they don't necessarily have the luxury like we do of having all three of these separated out fields, sometimes there is some of that overlap. But you're right about the home environment though, because what if they don't have a car? And what if they can't get to their medical appointments because they don't have transportation? That actually falls in the realm of social work. What else? What else do social workers do? Yes, go ahead. Potentially financial resources? Yeah, absolutely. Go ahead. Getting into psych wards, probably more of a nurse case manager field, actually. Potentially, it depends. But if they have psychosocial issues and they need resources for outpatient therapy services and things like that, definitely within the realm of social work. Absolutely. Yes.
Do you work with housing?
Housing, they can, yes, absolutely. So what if you have a homeless patient? We actually have a homeless patient, well, I don't know if he's been discharged, but we have a homeless patient in the hospital right now who has monkeypox, who has HIV, and so no one will take him because there's just no facility right now. And he requires IV medications to be infused. I think each infusion takes 4 hours or something like that. So a discharge plan for that particular complex patient is very challenging, right? Okay. So case managers, what do RN case managers do? Silence. So RN case managers are going to do a lot of the other medical stuff, right? They're going to help you set up their home IV infusions. They're going to help set up any hospital beds that might be necessary at home. They're going to set up home health. They're going to get patients transitioned to skilled nursing. They're going to help arrange for outpatient appointments to get the patient back within their insurance network. They're going to do all of those things, right? So, and sometimes there is that overlap like we talked about, but those are your RN case managers are the ones that are helping more with the medical aspect, like the actual medical care of the patient, as opposed to the psychosocial work, all right? But if you're lucky, you're going to have this triad set up. And then utilization management, we already talked about. So those are your nurses that are looking at the cases to make sure that we get paid appropriately for the work that we are doing and to try to prevent denials, okay? So that's the triad model. So if you hear that, then that's what that is. But you may not go to a hospital that has that, right? And so you might have to sort of seek out the case manager and say, okay, is this appropriate for the case manager? Do I need to talk to the social worker? But usually they'll get you pointed in the right direction if you just go up and ask. And frankly, that's the thing they want you to do. They want you to go up and approach them and say, hey, I'm trying to get Mrs. Jones home and I need a little assistance. They want you to go talk to them and talk to them about the needs of that patient and not just, I'm going to continue IV antibiotics for the next 24 hours. They want to know what the discharge plan is going to be. They want to know the plan for the day, the plan for the stay, the plan to go away. Those are the three things, right? So if you think of that, that'll help you along your way. All right. So we're not going to spend too much time on these slides, but I wanted to just kind of explain some of the other things because they're clearly, you guys as first years may not necessarily have a recognition of what care management actually does. So we're going to delve into that a little bit. So how can care management assist with the continuum of care and how does that parallel the care of the whole patient? Right? The things that you are learning in your tenets, how does that parallel? So we have rehabilitative or palliative services that beneficiaries receive after, or in some cases instead of, a stay in an acute care hospital. Things to consider. Does the patient even meet criteria for those services in the first place? Do they need durable medical equipment or DME? Do they need oxygen? Do they need a wound vac? Do they need a life vest? Is there any prior authorization that might be necessary from their insurance company? And while these things may seem to you like this is really not that important, trust me when I tell you this is part of the whole care of the patient. Making sure that the services that they require at home, that they will get what they need is your job as their provider. Okay, and care management helps you with that. So this is just a list of the various settings. Some of you may have already kind of heard of some of these, or this is the different places that patients can go when they leave the hospital. And I'll give you an example of one challenging case that we had. This was a little while ago. Patient had head and neck cancer, had his planned surgery, had all of his education classes prior to going into the hospital. They explained everything to do with the trach care and the tube feedings and everything else. He went through his surgery. He did fine. He was started on tube feedings, had his trach, everything's going well. And he was discharged home. And the one thing that was kind of left off the radar was the fact that his wife did not speak up and say that she did not feel comfortable caring for him at home. It was something that she just couldn't, she sat through all the classes, but when reality actually happened and he actually went home, she couldn't do it. She couldn't bring herself to suction the trach. She couldn't bring herself to take care of the feeding tube, the PEG tube. And so what happened? He landed back in the hospital, right? He readmitted right back to the hospital. And it was all because of something what you would think is relatively minor. It wasn't all the trach and the tube feedings and the medical care of the patient. It had to do with his wife's mental ability, really, to see her husband as still her husband and not a patient, if you will. So these are the things that have to cross your mind. The care of the whole patient is why this is so important, okay? So we're going to talk a little bit about some transfer situations. And for you first years, you may not remember this now, but maybe you will eventually when you start rotating in your third and fourth year, right? So, and we're not going to go over all of the specific definitions, but I know you guys, hopefully you will get the slides, and it just kind of gives you a background on each of these different transfer scenarios. Just things to think about as you're planning the care for your patient, right? So when patients are going out of the hospital, you have your skilled nursing facility placement. And that's if they're the nursing home, if you will. You have acute rehab. And so the difference between those two is that for skilled nursing, you do not have to have a 3-hour requirement. For acute rehab, you do. They have to be able to do 3 hours worth of rehab per day, not all crammed into one session, but they do have to be able to do that. And they have to show demonstrable improvement, the ability to be able to get up and move and improve with those therapies. There has to be a pretty significant drop in their prior level of function to be able to qualify for acute rehab. Long-term acute care, patients need to be in the ICU typically, and then moved out to that. We had a lot of LTAC placements after COVID. Those patients that were just lingering in the ICU for months, literally. And so we had to come up with a plan for taking care of those patients for long-term weaning. So that's where they would go for those scenarios. Inpatient hospice, obviously towards palliative or end-of-life care. And then hospital at home. So this is kind of a new advance lately, and something I think that's very important, again, for the mental and psychosocial health of our patients is being able to heal at home. You guys are on the forefront of this, right? It's very exciting. And to see where the innovations are going to go within the next, 19 years, since it's been 19 years since I've been back here, within the next 19 or 20 years, what the advances in hospital at home care are going to be and where we're going to be then compared to where we are now with this. My hope is that it will continue to expand, because the idea is that the patients are at home, they're still inpatient, they're still technically in the hospital, they're just not in the hospital. But think of what that does from a mental standpoint. You can sleep in your own bed at night. You might be hooked up to an IV, but you're in your own bed. You're there with your family, you're there with your support, you're there getting sleep and not getting woken up at 4 o'clock in the morning to get your vital signs taken, right? Or your labs or whatever. So think of the mental thing and the healing that comes from that if a patient is able to heal at home. So I'm very excited to see where a hospital at home will go, and you guys are going to be on the forefront of that. So it's a very exciting place for you to be in the position that you're in right now. So just other additional things to think about. Post-acute facilities, meaning out of the hospital. A lot of times the external facilities want to do their own discharge planning, and an inpatient provider's discharge instructions become even more important. If you think about, my mom is 91, and she hands to me some of the discharge instructions that she received from the hospital and said, "Here, I have no idea what this means." Okay. Now, mind you, I'm a physician, right? So of course she's probably relying on me to explain those things to her. But think of, an 88-year-old man who doesn't use the internet, who doesn't have access to the computer, who doesn't go online, who doesn't understand any of these things, and maybe has a low medical literacy, maybe doesn't speak English as his first language, and you hand him this giant packet of information and expect him to understand it and understand all the transition needs that he's going to have. It's your jobs to put all of that in there. Consider those other parts of their care, not just I'm discharging you from the hospital, but here, what do you have to do when you go home, and explain all of that to them. Be thorough about it. It's very important because you want to keep them out of the hospital. You want to keep them on their path of healing, right? So that's important for them to understand. And then for external patients, sometimes the primary care physician's offices or the primary care provider, they actually want to hear from the patient directly. So they want to schedule the appointment with the patient, because it's all well and good for us to schedule a follow-up appointment for the patient. What if they can't get there? If they can't fulfill the plan of care, then they might end up back in the hospital again, which is not where we want them to be. We want them to be getting better and at home and improving, right? So these are all things that you need to consider when you're setting up these discharge appointments. Are there agreements with outside agencies that you need to consider, because it might be a great benefit for complex discharges? And then who places those post-acute orders? These are all things you have to think about. I realize right now this is the least of your concerns. Right now you're worried about what? Anatomy, microbiology, pharmacology. Okay, all right. What else are you guys worried about? Do you guys have a test tomorrow? Oh, okay, all right, okay. So not too much pressure yet, but okay, all right. So I know that right now you're worried about that. I get it, right? I understand. So these are things that you're going to think about later. Trust me, when you come back and think, oh yeah, she told me about that. I was going to have to remember, right? Okay, so these are things that you're going to have to make sure that you remember. And so just things to learn within your healthcare system, because these are things that are going to influence the care of that patient. And there's a lot on here, which I'm not going to read to you. But this was actually a case. The one on the case on the left here with the 6 different things mentioned, that was on one patient. The skilled nursing facility had 6 different questions on that one patient that we were trying to discharge. And these are all the things that you have to think about. Why? Because you want to get them out of the hospital in a timely fashion so they're not getting to the skilled nursing facility at 8 p.m. at night. And you want to make sure that all the questions are answered because guess what? They might bounce back to the hospital if you don't. And how is that good for their mental health and their overall health otherwise? If they're bouncing back into the hospital, it's not. So these are the things that you have to take the extra time to remember, take care of that entire patient. Think of the things that are important to them and address all of that in your discharge paperwork because that's what's going to keep them hopefully out of the hospital and on their path and continuing on their journey to healing. Does the facility have their own transportation services? Another thing to think about. A lot of the times care management will help you set that up. So that's another thing to think about. Does the patient have transportation capabilities? Do they not? So these are all things that need to be on your mind. And again, you don't necessarily have to set these things up yourselves, but guess what? This is where care management can help you do all of this. Okay? So I thought this was a great quote from Dr. Still. Right? When a man works with his hands, he is a laborer. When he works with his hands and his mind, he is a craftsman. When he works with his hands, his mind, and his heart, he is an artist. You are all artists in training. Medicine is an art just as much as it is a science. And you need to remember that and keep that close to your hearts. The position that you all are in, at least as first-year students and the second-year students next door, and I know the attendings that are online can probably relate to this as well, in our daily practice of medicine, and it doesn't matter whether you continue to see patients or whether you end up doing administrative work, this is why we do what we do. It's the care of the whole patient. And so it's an important thing to remember. I just thought this was very profound because it really really speaks to those tenets that we learned so well here in our first couple of years in Kirksville, and then on in our clinical practices, respectively. So how are they the same, right? I shared earlier with you, care management and osteopathic medicine have some strong parallels. And even when I was preparing this lecture, I looked at this and I thought, wow. It's like, if I had only known, right, 19 years ago or, 23 when I was first-year student, remembering this and keeping this close to your mind. This is the reason why you are all here, to take care of human beings, to take care of patients, to really do that to the best of your capabilities. That's why you're here. You're here to care for each other. You're here to care for those patients, their families, their loved ones, their friends. And all of this is inherent within what care management does and within the tenets of osteopathic medicine that you study on a daily basis. So remember your big picture. Remember your why. Remember why you're sitting here in these seats. Remember when you're studying for your pharmacology test at 3 o'clock in the morning and you're really tired and you need coffee and you can't get any more Diet Coke down or it's not possible to drink anymore because you'll just, Remember your why in those moments when it's really, really hard because there is a good reason as to why you're here. And this is why, if you think about it, okay? I thought it was interesting to just do a Google image search of what comes up when you look at care management. What do you guys see when you look at this? This was just the screenshot of when I did a Google search, this is what popped up. What do you guys see? Oh, come on, you guys. Yes, in the back. Oh, older patients. Okay. All right. Yeah, fair enough. Okay. What else? Yes. Collaboration. What else? Lots of conversation. Okay. I think you had a point too, right now? Maybe not? Okay. All right. What else? There's a lot more up here. Yes, go ahead. Lots of smiles. Okay. All right. They probably knew they had their picture being taken at the moment. Okay. All right. Lots of different providers. Okay. What else? Yes, in the back. Personal. Okay. All right. I like the comment about lots of smiles, although it was probably posed. I get it, right? Okay. But what I see here is people caring for other people. That was when I looked at that, I was like, wow, they're all, for the most part, there's a few like digital images and things like that, but it's a human being taking care of another fellow human being. And if you think about it, the mind, body, and spirit, those are the things that are going to motivate you as you care for your patients. And that's what care management is all about too. So just thinking about those things, taking it back down to something very central and simple as this, honestly, is where you need to be. Sometimes in the hardest times, these are the times that you need to remember. There were a couple of images that stood out to me, actually. And I thought that this one, I'm not going to read this to you, but I thought that this one was actually really important because it really does describe some of the other things that, things that care management does between assessing the patient, coordinating their care, supporting the patient. There's a lot of, even like there's one thing at the bottom there, it says, provide an extra pair of eyes and hands. They're there to help you. Just as you are taking care of that patient, so are they. They are part of the team. It's not one person that's doing this. You're doing it in conjunction with all these other people to help you, okay? And then I thought this also was an important point to make as well, because there is a slight difference between care coordination and care management. So the definitions are there for you to read, but it really explains the difference between what care management is, meaning that it's usually acute care based in the hospital. It's more episodic. My uncle left the hospital. He has a lot of back pain issues, and he left the hospital and asked me, he said, can I contact the social worker that I saw in the hospital? And I said, no, you actually can't, right? So he needed someone to kind of help him, and of course I obviously did, but it's episodic care. It's only while you're in the hospital. So that's the difference between that and a care coordinator who would kind of help him on an outpatient basis, okay? How can I help? That should be one question that you guys should be asking too, right? What are the fundamentals of what you're learning in medicine? How can I help you? How can I care for you? I see you. What do you need? Those are the things that you need to be asking your patients and the other providers that you work with. Help each other. It's not just about taking care of your patients. You guys are here to help each other too. Help your fellow students. Be there for each other. You're all going through it together, right? So remember that. Remember when you're residents and it's, you're both on call at night and it's 2 a.m. and you're exhausted, help your fellow students, help your fellow residents, be there for each other. And then self-management, right? Don't forget about yourself in this whole process. And we'll talk about that in a minute. A few more images that stood out here. And this just kind of really showed, again, what is the total picture of what care management does for the care of a patient. Again, it's not just the medical care. That is one very important piece, obviously, but all these other things are the things that care managers will help you with when you're in the hospital and even in the clinic and otherwise. Look at all those things that kind of, I thought, paralleled to the tenets of osteopathic medicine. You've got nutrition, social services, behavioral health, health issues, functional abilities. It's all well and good if the patient can't get up, you get them home, but they can't get up the stairs that are leading up to their apartment, right? Cognition, mental health, their living situation, their support system. And then what does it say in the center? Care managers understand the whole person. So this last part of this talk, we're going to spend a little bit of time talking about ourselves. And since I'm up here, I'm going to talk about myself. And how you can apply these concepts to your own selves. So be there for others, but never leave yourself behind. And sometimes when we're feeling stressed and running around taking care of everybody else, the healthiest thing we can do is to stop and consider how we can take care of ourselves too. Self-care is essential for all of us, but it looks different from person to person. We're all individuals. We have different practices. Listen to your inner voice and find out what makes you happy. Find out what makes you content. Sometimes we can't even hear that inner voice because we're so busy anticipating the needs of everybody else. You're all caregivers. That's why you're in medicine. That's why you're here, right? So it's very easy to lose that awareness of yourself and the care of yourself in the process of this whole education process that you're going to be going through. And I know the attendings that are on this on the call can probably, or on the live stream can probably speak to that for sure. We're so busy taking care of and anticipating the needs of those that we care about, so you might have to listen pretty carefully to that inner voice. But what I'm going to say to you is, remember what brings you joy. Remember why you're here. I'm going to share with you a little bit of some personal stories now. So I was here more than 19 years ago, and I was a student, and my dad had non-Hodgkin's lymphoma, and he passed away while I was here. So he never got to see me graduate from medical school, and he'd be very proud that I'm standing up here giving this talk. So part of why I'm here is to honor all of you guys, to honor Dr. Tinning and his family. But one of the main reasons for myself is to honor my dad, because he would be so incredibly proud of the work that I'm doing. I work for Mayo Clinic. I mean, he's probably pretty excited about that. My mom certainly is. And so going through the death of a parent, and I mean, I'm not saying to you that all of you have to go through, at that time through medical school and everything else, but I went home and I had to really look inside myself and really decide, was this really what I wanted to do? Was medicine the right path for me? And it takes a lot of self-discovery and self-awareness. And so what I'm going to tell you is this, is that it's okay to be uncertain, but know yourself well. Trust your gut. It won't steer you wrong. Your gut will lead you in the right place. If you get excited about going back to the hospital and you're excited to be on rotations, and even though you're tired as all get out and it's so exhausting and it's, you've been up for 36 hours and you're just, burned out and tired and everything else, but you're still happy with what you're doing, you're on the right path. Pay attention to what makes you happy. Pay attention to what brings you joy. What makes you just excited to get in there and do it. And even if it's hard work, it's not hard work if you really love it and if you really enjoy what you're doing. And that is what is fundamental to what you're learning here, right? Mind, body, spirit. Connect yourselves to your minds. Connect yourselves to your bodies. When you're tired, sleep, if you can, right? When you feel like you just need a mental break for 5 seconds to just exhale, do that. That's okay. But then get yourself back up and move on. And keep doing what you're doing. And that's what I want you guys to really hopefully learn from doing this. After losing a parent when it was so difficult here, getting through classes and everything else, it was a big challenge. But I pulled myself up and did it. And you guys can too. The last couple of years has been a big challenge for all of us in healthcare. It has not been easy. I work for Mayo Clinic. We're very lucky to not have been exposed to some of the real challenges that we saw across this planet, right? We've had PPE. We didn't have to worry about those kinds of things. But we've all been touched, I think, in a way that none of us anticipated before COVID came into our lives. I personally have been touched. I lost my best friend to COVID. And she would be extraordinarily proud of the fact that I'm standing up here doing this as well. She was a guidance counselor and she worked with special needs kids. And so she was an educator and she believed in the things that I think I've spoken to you about today. With that, I'm going to show you a picture and then I'm going to pause for questions. My dad's saluting you with a cup of coffee, so with that, I will say thank you. I appreciate your time and your attention, and I will open it up to any questions from anyone. No questions? Oh, come on. It's okay.
Comments?
Yes, go ahead. Okay, so the question is, how did I get to this path? So kind of accidentally, actually, and partially because of my obsessive compulsive tendencies. Just a few. So in about 2014, 2015, one of my partners, who was the medical director, my role now at the time, he kind of tapped me on the shoulder and said, you're really good at this documentation stuff. Do you want to be a physician advisor? And I said, what's that? So a physician advisor is kind of an intermediary leadership position. I see it as someone who sort of straddles administration and then the clinical practice. And so you are the link because you're still practicing clinically, but you also see the insurance side of things. So physician advisors are we're kind of like the clinical consultants for the care managers. I work very closely with the utilization management team. I do a lot of work with denial management. I talk to medical directors from insurance companies all the time and try to fight those denials. And I'm so passionate about this work because, in my opinion, it's the right thing for the patient. It's the right thing for our hospital. hospital, it's the right thing to do to get paid for the work that we are doing, right? And so to try to prevent those denials, and all of that is included in your clinical documentation, how you write your notes. Hopefully, wherever you go on your rotation, someone's going to educate you about clinical documentation integrity or CDI. And if not, you call me and I'll do it. It's fine. So that, I think, that kind of summarizes it for you. But it really had to do with just somebody tapped me on the shoulder and said, "You're really detailed and really good with this. You might be good at doing this." And that's when I got involved with the ACMA, or the American Case Management Association, was after that. Other questions? Yes, in the back.
How often did you change your mind about the specialties you wanted to get into?
How often did I change my mind about specialties I wanted to get into? A lot. So I didn't really know what I wanted to do when I was a first-year student, even going into second year and really even into third year. And then I thought, okay, family practice is good because it's, you kind of do everything, right? And so you get to see everything and you don't necessarily have to pick one particular thing. I knew I didn't want to be a surgeon, not my thing. I'm glad that there are surgeons in this world, but just ask my husband. He'll tell you that I can't find my head if it wasn't attached to my body. So surgery was not for me. So I knew that I kind of wanted to do a little bit of everything. And so I thought family practice was good. And I actually thought that might be a good place for me. But then when I got into clinic, I found myself being excited to go back to the hospital. And I never really felt competent with kids. It just didn't click in my brain. I just didn't get good at it like I thought I should be. There's my time limit for 10 more minutes. And so I thought, okay, well, I don't have to see kids, and I don't really have to practice in the clinic if I don't want to, and I didn't want to do OB because it's just, again, surgery. No, not my thing. So then I thought, well, wait a minute. If I don't want to be in the clinic as much, and I like the hospital, and I don't necessarily want to see kids, and I don't want to do OB, then what the heck am I doing in family practice? That doesn't really, I could if I wanted to, but I didn't think I was good enough for internal medicine. I really didn't. And so, because all those people that were internal medicine were really, really smart, and I thought, well, maybe I can do this. And so I spent some time in the ICU and did some additional medicine rotations, and that's when I said, all right. And I listened to my gut, because I was excited to be doing it, even though it was really hard. And I thought, I don't know if I'm good enough for this, but I did. And that's when I chose internal medicine and never looked back. Hospitalist medicine is challenging because the patients are sicker and you're running around and you never sit, and it can be a crazy long day, but the acuity was what really drew me to hospital medicine. And I still see patients, not as often as I used to, but I still do. And so that's why I chose what I chose. But again, it comes down to listen to what your gut tells you. It won't steer you wrong, I promise. Other questions? Yes.
If you find yourself in a location where you don't have all these resources that you've been talking about, what are some of the things you can do to manage that?
Yeah. Okay. So the question was, if you find yourself in a place like a rural environment or something like that where they don't have all of these resources, that's when, they will have something. They have to have something for discharge planning, right? Because you have to be able to get the patients out of the hospital somehow. So just find out who your resources actually are. Find out who does what, and then go from there. They have to have something. They have to have something to help plan for discharge, for getting patients out of the hospital into skilled nursing or home health or something like that. Chances are they may not necessarily have the separation of the triad. They might have a dyad model where it's social work and then the RN case manager and utilization management, kind of the RNs doing all of the RN work. Probably is what you'll see. You may even see social workers doing some of that discharge planning as well, but chances are they'll have something. It just may not be quite as separated as what you saw here. That's more of the ideal state, but they will have something. Yeah. So just for what you can do is be in touch with those people, whoever they are, whether it's the social worker, the case manager, whatever. When you know what you're doing with that patient, or even if you don't, hey, I think I'm going to be sending Mr. Jones home on oxygen. I don't know how many liters yet, but I wanted to let you know. That's how you can do what you need to do to help them do their jobs, to transition care. Other questions? All right. Well, I'll be around if you guys have anything that you want to ask and don't want to ask in front of everybody else. I wish all of you luck. You're in an amazing position. You're in an amazing school. The training you will receive, trust me when I tell you, it's top-notch. Maybe I'm a little biased, but but it is top-notch, and you will be outstanding when you graduate. Please remember who you are and why you're here, and it won't steer you wrong. So with that, I thank you. Oh, there we go. Yep.
All right. Thank you very much, Dr. Peters, for being here and being our honored guest today. We really appreciate you coming and speaking at the attending lecture. I want to present you with this plaque in commemoration of your visit. So thank you very much.
Thank you so much.
Thank you all for being part of today's beginning of the Founders Day celebration. Again, I want to thank you, Dr. Peters. We are so grateful. Dr. Tinning would be so proud that you have delivered on what the intent of this day and this event is. And we thank you, and we're so proud that we can call you our own. So thank you all. Have a great day. I hope you get to enjoy many of the things that will be going on, particularly tomorrow. We look forward to seeing you. And again, have a good evening. Thank you.